good morning, evening, afternoon, and so on to you. And welcome to this third of the series of 5 webinars of the second Wood Burns Week. I am Ronan Lefloc. I was intensivist and anesthetist in Nantes. I'm a member of the organizing committee of Wood Burns Week, and I will chair together with Dominique Potokar this session. This session is about preventing the complication of burns with the 4 more pregnant are infection, pain, retraction, and psychological sequelae. So our first speaker will be Samira Ege from the United Arabic States, I would say. She is a senior nurse and she is involved in burns and especially in burn infection prevention in Abu Dhabi. So please, Mrs. Samira Ege, go on.
Hi, good afternoon, good evening, and good morning for everyone. Is my slide on? Yes. So today I will speak about infection prevention and infection prevention complication in burns unit. So next. First of all, infection happen when harmful bacteria and virus such as fungi and parasite enter the body, multiply, causing damage. An infection, if not detected early, or treated early, can. Thank you. An infection, if it's not detected early or treated correctly, may lead to sepsis. Next. There is many causes of infection. Next slide. Yeah, there is many causes of infection in burn patient, such as loss of skin barrier, as our skin is the largest body organ and the first line of defense, and also the presence of invasive line, such as catheter, central line, and other device such as ventilation, and environmental, such because of poor infection control practice and prolonged hospitalization, especially with the larger surface area involved. Next. The causes of infection and burn can be internal and external factor. The internal factor is the pre-existing normal flora in the patient's skin, pre-existing conditions such as diabetes, hypertension, and cardiac disease, age, especially with pediatric and elderly being more prone for infection, and as I said before, larger body surface involved, especially more than 30%. External factors such as water contamination and contaminated equipment and colonization, and healthcare worker due to lack of hand hygiene and poor infection control practice. Next. Complication in burn patient can lead to systematic acute complication and delayed chronic complication. Systematic acute such as sepsis and organ failure, which is the leading cause of mortality and morbidity in burn patient. Shock and dehydration, hypothermia. Delayed such as scarring, contracture, and pain, skin changes, and depression and anxiety. Barrier to implementing proper infection control in burns unit can be due to inadequate and lack of necessary PPE and hand washing facilities, poor maintenance of the facility and waste management issue, and lack of maintenance of practice such as unsafe reusing of equipment. Next. Barrier to implement proper infection preventive measure can be due to lack of or inadequate training and poor adherence to protocol, and high workload, especially if the staff are facing with a lot of workload they may do shortcut or they don't have enough time to do proper hand hygiene or infection preventive measures. Management issues such as lack of support, engagement, communication. Actually, it's next slide, please. and can lead to proper implementation of policy, non-compliance from the staff, from patient and family, which may result in spreading of infection or pathogens. Next slide, please. Preventive intervention to infection can be done through precaution and isolation of burn patient, environmental control, surveillance and monitoring, antimicrobial stewardship, and multidisciplinary approach. First of all, next slide, please. Precaution and isolation of burn patient can be done by using standard precaution for all patients, place patient in separate room or cabinet if possible, assign dedicated nursing staff, and attend to infected patient and patient last. Use of proper sterilization and disinfected instruments. Clean thoroughly and disinfect patient area, and enforce visitor policy to limit infection spread. Next, please. And implementation of strict infection control practice such as hand hygiene is the first line defense through for infection control. And remember, all proper hand hygiene is everyone's responsibility, and it doesn't take a long time, and it can be a powerful method to stop spread of infection, because our hand is the most source of spreading infection in the unit and cause nosocomial infection. Next, please. Environmental control through maintaining proper waste management, regular cleaning and disinfecting of surface and equipment to minimize environmental contamination, implementation of isolation protocol for patients with resistant infection and ensure proper ventilation system, ensure availability of hand hygiene supply, water source, and cleaning material. Next, please. And the third point is antimicrobial stewardship. And under this one, we should do sensible use of systemic antimicrobial and to prevent development of resistant organism. Antimicrobial antibiotic therapy should be guided by culture result limited to confirm infection, and develop of local policy and program in healthcare setting to avoid overuse of antibiotic. And antimicrobial dosaging should be set via tailored PKT, ideally using real-time therapeutic drug monitoring. And if it's not feasible, we can use Monte Carlo stimulation, and which can be useful. Next, please. And the most important thing is multidisciplinary approach, as adopting multidisciplinary approach and burn care especially is crucial to eliminate infection, as everyone will take responsibility and every member of the team are key component in succeeding of this approach, and everyone contribute from physician, nurses, dietitian, housekeeping team, and physiotherapists, and ensure the whole team receive adequate training and information how to prevent infection and infection spreading, and to maintain optimal possible outcome for the patient. And in my personal experience in infection prevention in burn unit, where I worked for 7 years, we did multiple steps, such as developing strict policies and guidelines for antimicrobial stewardship and follow it, and making sure that everyone is aware, and initiating early nutritional support, developing dressing change protocol, and dedicating staff for that, and they will do the infected patient last. Environmental control, such as having dedicated cleaning team, and this team was well trained, and they will not be going to another area, so they were only dedicated for burns unit. And strict adherence to hand hygiene, and from patient to nurse to healthcare worker to patient family, and hand station was placed in an area that the patient and family will not go inside unless they wash their hand, and when they come outside also they will wash their hand, and having periodic audits to ensure adherence to this protocol. And infection prevention and preventing the infection was part of our KPI, so it was measurable and it was part of our audit, and in a periodic this is my reference, and I will happy to answer any question. Thank you.
Thank you, Samira.
Thank you, everyone.
I hope you will receive some question in the Q&A. We had one in the chat. Please put it in the Q&A section. Anyway, I wrote it down. So the next speaker will be Mathieu Jeanne. Mathieu Jeanne is an anesthetist and intensivist in the burns unit of Lille, of which he is the head doctor, I would say. And among his multiple research, pain is one of its most usual. So please, Mathieu.
Thank you very much. Thank you to the organizers for inviting me to present how we work in Lille. I am the head of the burn center here in Lille. We have an active file of 500 patients a year. 80% of them are ambulatory, and the rest needs intensive care or critical care. I wrote this presentation in combination with our psychologist because all our approach to burn patients is multidisciplinary. So the question is about preventing pain-related complications. In my experience, pain-related complications occur once burns are finished in a way, but the pain remains. This leads to trauma and to chronic pain when the pain is there for more than 6 months. All our work over the last 10 years in our center has been to develop all treatments, analgesic treatments, in order to avoid these chronic pains in our patients. And I must say, the patients who still present to us afterwards with chronic pains are the ones for whom we had problems in dealing with acute pain. The other ones usually go back to normal with only very little chronic pain incidents. The main problem with our critical care patients is that resemble the invisible man. They are most of the time unconscious, either because of the traumatic injuries or because they are sedated. And most of the time they are sedated for 3 to 6 weeks, depending on how fast we can wean them from sedation and from the ventilatory support. For these patients, we have problems in evaluating their pain and in choosing the analgesic regimen for them. There is research ongoing about autonomous nervous system monitoring, which is probably helpful, but is still research. Otherwise, we need nonverbal pain scales, for example, like the BPS, which is quantified by the nurses every 4 hours or every 6 hours. And sedation and analgesic are adapted in order to maintain this score rather low. You see that it relies on facial expression, which is sometimes not available when there are facial burns, on upper limb movements, and on compliance with mechanical ventilation. So it's absolutely not a specific score of pain. It's rather a combination result of sedation and analgesia. Once the patient becomes conscious, we can use the visual analog scale in young adults and adults, but not in children, where we need the flag score, for example, where we go back, like in the BPS score, to face, legs, activity, cry, consolability. This is for children up to 7 years. And for the older children, from 5 to 16 years, we can use the faces pain scale, where the child has to recognize which face would most express what he is feeling. The problem with burns is that it leads to strong biological inflammation, and inflammation leads to amplification of pain. So controlling inflammation would be a kind of magical treatment for pain, but we don't have found yet this magical treatment for inflammation. So we need to deal with the burns and the inflammation they provoke, and take into account that this inflammation leads to an amplification of pain. Burn pain is a combination of several pains. There is this background pain at rest, which needs to be interrogated in patients, for example, who cannot sleep. They need to receive slow release painkillers in order to treat this background pain. Acute pain or procedural pain needs short-term painkillers, and then there is this neuropathic pain which takes 1 or 2 days to appear, but then can be very invalidating and needs to be taken into account with a specific scale. Painkillers for the non-neuropathic pains can be associated between the step ones, which are the simplest drugs like acetaminophen or non-steroidal anti-inflammatory drugs. Step 2, which are weak opioids like tramadol or nalbuphine or nefopam, and they can all be combined, and we do it on a daily basis, and it really works. And if need be, which is frequently the case, I would say 1/3 of our patients needs strong opioids, these step 3 opioids. We use oral morphine or transdermal fentanyl. So in children up to 15 years, I'd say we use a lot of acetaminophen and tramadol, and usually it does the trick. And when they are hospitalized, then we go to morphine, usually orally in a kind of syrup. For adults, acetaminophen is a base. Nefopam also is a base. Instant release morphine is orally in case of acute pain, and we really need to teach the patient how to take his medications, but it works quite well. And this slow release morphine is for the background pain. We usually use 10 to 20 milligrams twice a day. And for people with very strong pains, or because they are elderly and they don't catch exactly how to use this oral analgesia, transdermal fentanyl is working quite well. Just a message of warning against non-steroidal anti-inflammatory drugs. They are very, very efficient, but we need to be aware of the side effects in case of infection or renal failure. So we put them mostly after surgery when we are sure there is no infection in the wounds. Considering neuropathic pain, the DN4 questionnaire is systematically asked by our nurses twice a week when we see our ambulatory patients. The questions are quite different to those of acute pain or background pain, because they turn around a feeling of burning or a feeling of painful cold. Electric shocks are very frequent. Also the pins and needles and the stinging in the wounds. Other information about hypoesthesia or hyperesthesia are very difficult to quote in burn patients. What needs to be remembered is that these neuropathic pains react very good to small doses of gabapentin as long as it is started very soon. So we start usually gabapentin in our center 2 or 3 days after the burn, and with this we have very good results. For the burn wound dressing, which leads to anxiety and fear and acute pain, we most of the time use sedation in children from 3 years old and in adults. For children, the use of the Mapleson bag and the Guedel cannula is just the rule, and we proceed with induction with sevoflurane, and we put an IV line, and then we titrate alfentanil on propofol. And I'd say this is our basic formula, and it works in every kind. Of course, you can add a lot of other medications. They all work in combination with one another, but it doesn't need to be complicated to be efficient. The very simplest ways to do anesthesia are very efficient. For adults, we don't do the sevoflurane induction. We directly go to IV line and alfentanil with propofol. Every time it's possible, it's interesting to use also oral sedation. And this is a clinical trial in children where most of the time oral medication and premedication did the trick, so that it was possible to avoid general anesthesia in more than 90% of the cases. If need be, of course, IV sedation and anesthesia are possible. In this case, they use remifentanil a lot, which is not our practice. We use alfentanil or sufentanil. We use remifentanil more during surgery. Hypnosis is very, very interesting, especially in children. You see here a young child who is just playing. She did not come to us for burn care. She came to us because she wanted to play, and we play every time we see her. We play every time we see a child. We make music. We make just decoration of the facial mask for anesthesia. We sing with the children, and for adults we use a more classical Ericksonian hypnosis, but for children, playing is just a trick. And so once it comes to induction of anesthesia, you see the child just assembling the mask on the Mapleson bag and inhaling quite happily the nitrous oxide and sevoflurane, and you hear the encouragement of the nurses, and they are dancing with her. So there is a way to avoid trauma or other trauma related to care by using hypnosis. Thank you for your attention, and if you have questions, I'll be happy to answer. If you need me, here is my contact per mail. Thank you.
Thank you, Mathieu. Very good point. You pointed out the chronic pain and specific questionnaires for it, because I believe few pay attention to it. So our next presentation will occur a little bit further in the course of the patient, but its prevention starts as soon as after the burns. It's the contractures. And please, Ruth Ann, go with your presentation. And turn on your mic, please.
I'll try again. Hello, everyone. I'm Ruth Ann, and I'm really delighted to be speaking today on a really important topic of prevention of burn contractures in low-income countries. And thank you for your solidarity in being with us today. I will just stop my slides. Are they visible?
Yes, it's okay. You can keep on.
When I first met Rahima, she was 5 years old. Her hands were clenched tightly into her palms, not from pain, but because the skin had scarred and tightened so much she couldn't open them. She looked up at me, she smiled shyly and tried to wave, but her fingers wouldn't move. That moment, and many similar ones, stay with me. It's one of the countless reminders that a burn contracture is not just the scar. A burn contracture can be a story of lost potential. So what is a burn contracture? It's an impairment caused by skin with pathological scar tissue that has lost its normal elasticity and length. As a result, movement is restricted and the alignment of the affected joint or body part is altered. As listed here, contractures can have a profound impact on every aspect of a person's life, including on their loved ones and community. These are all people that I've met during my work, many of them recently. You can understand something of the impact of contractures just by looking at these photos and imagining life for these people. Not only the physical and functional limitations, but also the psychosocial impact. Surviving a burn injury is hard enough. Living with its consequences can be a lifelong challenge. While these examples show more severe contractures, even very small contractures can drastically reduce someone's quality of life. For those of us working in acute burns, we often see the beginnings of contractures forming right underneath our noses. They can start in the very earliest stages of recovery, and our work begins immediately. As physiotherapists, much of what we do is dedicated to preventing and treating contractures. And in low-income countries especially, that work can feel like an uphill battle, with many barriers to overcome, both for the treating team and the patient. It can really feel like a fight. But every stretch, every splint, every moment of care truly can make a difference, not just in the moment, but to the patient's future. If contractures are so common and so devastating, the next question we must ask ourselves are they preventable? Through years of working in both high and low income settings, I've noticed significant disparities. Two patients with almost identical burn injuries could have completely different outcomes, depending entirely on where they were treated. The difference, I came to realize, lay not just in the burn itself, but in the system surrounding the patient. That observation inspired me to explore whether burn contractures could act as an indicator of the quality of a burn care system, a concept that was not established in the literature. And so my research began with this question here that you can see on the screen. To answer this question, we developed a data collection tool to identify the risk factors for burn contractures among survivors in Bangladesh. If you'd like to explore the details and results of these studies, all the publications are open access and available on the Dr. Contracture website. Before we could even study risk, we had to define and measure what a contracture was for the purposes of the study. That was no simple task. Developing consistent ways to assess contractures is vital for prevention of contractures and remains an important research gap, particularly in low-income countries. On this slide, you can see some of the risk factors for burn contractures identified across our studies. Those listed on the right were found to be statistically significant for either the presence or the severity of a contracture in our Bangladesh cohort. You can find more information in the publications. Most research on burn contractures comes from the high-income countries, yet the key risk factors in low-income settings are unlikely to be the same. In resource-limited contexts, broader factors such as social economic status of the patient, access to early specialist and ongoing care often have greater impact because they're not controlled for in the same way as some high-income settings. Prevention strategies must be therefore context-specific, supported by more research in the places where contractures are most common and severe in the low-income settings. You may have expected this talk to focus mainly on treatments for preventing contractures, and absolutely, they're totally vital. But treatment is only one part of a much bigger picture. Every member of the burns team plays a crucial role: surgeons, nurses, therapists, psychologists, and social workers, and others. For therapists, the work starts on day one, identifying high-risk joints or features early and moving in the opposite direction of expected loss of movement through positioning, splinting, play, movement, exercise, and scar management. We help prevent and treat contractures. In high-income settings, I usually found that I could use a full range of treatment tools supported by a multidisciplinary team and good resources. But in many low-resource settings that I've worked, it's a different story. And as a physio, I've often felt my hands were tied, overwhelmed by high volumes of patients with severe injuries, late presentations, unmanaged pain, months of open wounds without grafting, and little or no follow-up. And in such circumstances, it can feel and be almost impossible to prevent contractures. Take Aisha, for example. Her injuries could lead to two very different futures. Without optimal care, she could spend her life unable to walk or participate fully in daily life. But with coordinated, comprehensive care, she could be mobile and contracture-free. She needs support on every level: physical, psychological, surgical, therapeutic, including nutrition, pain management, wound care, splinting, and positioning, all within an accessible system. Sadly, Aisha now lives the first of those futures, as she's already developed fixed contractures of the hip, knee, and ankle. I've tried to summarize some of these principles in the acronym STOP. Stop contractures. Support. Having a burn injury is incredibly difficult. Patients need ongoing support, financial, emotional, and social, to access and sustain care. Without it, even the best medical treatment can fail. Time and therapy. Timely specialist care from the start is essential. And therapy, physical and psychological, must continue as long as needed. Operate. Early wound closure, often through grafting, is vital to reduce scarring, infection, and pain, common drivers of contracture. Pain management. Effective pain control allows patients to participate fully in rehabilitation and regain movement and function. From my clinical experience and research, I've come to believe that contracture rates reflect the quality of a burn care system. In one of my publications, I've proposed that a contracture incidence and severity offer a simple yet powerful indicator of the health of a burn care system. When we focus on reducing contractures, we will inevitably strengthen the whole system, because prevention will require improvement across every stage of care. A burn contracture is not just a complication. It's a marker of inequality and a sign that something in the system somewhere needs attention. As I come to a close, I'd like to leave you with a few questions to reflect on. Unfortunately, there's not time enough to talk through these, but maybe in your own time, you can consider them. I'd like to point you to this resource as a place for publications on contractures, and I recommend that you share your story, whether a healthcare professional, survivor, or professional with experience with burn contractures. Countless burn survivors like Rahima and Aisha live with contractures that could have been prevented. Most will never have a platform to share their experiences or get the help that they need, yet they live every day with the consequences. Together, we can use our collective voice to stand alongside them, to bring their stories into focus, and to mobilize the expertise and resources needed to stop contractures and the unnecessary pain and suffering that they cause. Preventing contractures is not the task of one profession, one sector, or one country. It's a test of how we work together. Preventing contractures is not just about treatment. I believe it's about justice. I'd like to thank you very much for your time and attention today.
Thank you very much, Ruth Ann. Your point of view on the link between quality of care and contracture is really, really interesting.
Thank you.
As for the last speaker, I would invite Eva Filage. Eva Filage is a psychotherapist in Burn Center of Tirana in Albania. And I really want to thank her to have accepted speaking in World Burn Week. Please, Eva.
Hello, everyone. Thank you, the organization committee, for this invitation.
Eva, est-ce que tu peux mettre ton micro plus fort?
Oui, je pense. Je vais augmenter le volume.
Ou t'approcher, on t'entend très mal.
Au maximum. Oui, d'accord. So my presentation for today is the prevention of psychological disorders in burn patients. A burn is not only a physical injury to the body, but also a deep wound, often violent, sudden, and overwhelming. Burns trigger a major systemic reaction. The body responds as if to extreme trauma. Next, please. The patient experiences their burn as an extremely difficult physiological, psychological, and social event. In the physiological aspect, we have pain, shock, infection, metabolic disorders, scarring, loss of mobility. In psychological aspects, we have fear, anxiety, depression, post-traumatic stress disorder, altered self-image. And the social aspect, we have isolation, reintegration difficulties, and stigmatization. Psychological complications in burn patients are linked to several factors. First, we have severity and circumstance of the burn. Then the individual or personal factors, social and relational factors, and factors related to medical care. Next, please. Severity and circumstance of the burn. Extent and depth. The more severe the injuries, the greater the psychological shock. When visible areas are affected, we have a strong alteration of body image. Intense pain and prolonged treatment maintain fear and anxiety. Sudden or violent nature of the accident, risk of major psychological trauma. Long hospitalization in a sterile unit, sensory and social isolation, increasing distress. Next, please. Related to individual or personal factors, we have the young age. Young age entrain a greater sensitivity to body image and self-esteem. History of psychological disorder like anxiety, depression, previous trauma. Lack of coping strategies with difficulty in managing stress. Perfectionism or low self-esteem prior to the accident. Introverted or dependent personality, more vulnerable to isolation and shame. Next, please. Related to social factors, the lack or weakness of family and social support promotes isolation and feeling of abandonment. Economic difficulties or job loss after the accident. Negative social perception or stigma like mockery or rejection. Relationship or marital difficulties after the burn. A demanding or unsupportive work environment increases guilt and fear of not being like before. Next. Thank you. Factors related to medical care. Poorly controlled pain during treatment reinforces the trauma. Lack of communication or empathy from the healthcare team reduces the patient to body to be treated rather than a human being. Absence of early psychological support leads to loneliness in the face of suffering. Repeated surgical intervention causes emotional exhaustion and fear of the future. Next, please. But why it is so important to prevent this psychological complication? First of all, to promote overall healing, to prevent psychological suffering from becoming chronic, to maintain motivation and participation in treatment, to preserve self-image and quality of life, to facilitate social and professional reintegration. Next, please. How to prevent psychological disorder in burn patients? The first point is the early psychological support. From the very first day of hospitalization, it is essential to begin verbal therapy to help the patient express the shock, fear of dying, or guilt related to the accident. Verbal support and a caring presence help prevent the trauma from taking root. The second point is effectively relieve physical pain. Poorly controlled pain sustains fear, stress, and emotional distress. A patient without pain is a patient who can rebuild themselves. Next slide. The third point is create a climate of trust and with the healthcare team. The patient must feel heard, respected, and understood. Every treatment should be explained with a warning before any physical contact and reassurance during painful procedures. Empathy and clear communication reduce anxiety and encourage cooperation. Next, please. The next point is preserve the patient dignity and privacy. Burns often expose the body, leading to feelings of vulnerability and shame. It is essential to respect modesty and protect privacy as much as possible. This helps the patient maintain a positive self-image and regain confidence. Next point is support the family and close ones. The family also experience shock and may transmit their anxiety to the patient. Caregivers should involve the relatives, explain the progress, prepare them to see the wounds, and encourage them to maintain emotional bonds. A supported family becomes a source of healing. Preparing the patient for social reintegration. From the rehabilitation phase onwards, it is important to address the reconstruction of body image and life after the hospital. Support group, patient association, physical therapy, and occupational therapy help to regain confidence. Concrete project, work, studies, leisure encourage looking ahead to the future. And the final point is ensuring a long-term follow-up. Psychological trauma may reappear later in form of dreams, nightmares, social withdrawal. Regular follow-up after discharge allows support to be adapted to the patient pace and help prevent relapses. How can we achieve this? Train healthcare staff in empathetic communication, involve family and close one as psychological support, create a human and respectful environment in the hospital, manage pain as effectively as possible with available resources, encourage social connection. Strengthening social bonds is often the final stage of recovery for a burn patient. It is also the most difficult, as visible scares, fear of other judgments, and loss of confidence can lead to the patient to isolate. Promote peer support meetings, organize support groups, encourage group activities, raise community awareness about perception of burn survivors, rely on local or religious community support. Psychological after effects are predictable and preventable. Even with limited resource, a lot can be done. The community and family are key players. Complications are in the end, they are a chance to mend. Thank you for your attention.
Thank you, Eva. You told me you were not very confident in your English. It was completely false. Now I will give the microphone to Dominique Potokar. For those who doesn't know Interburns, she is coordinating and nurse point of view in Interburns, and she will lead the Q&A session. Please, Dominique, take your mic.
Hi, everyone.
It seems that Dominique is frozen right now. So Renaud, are you able to take over the Q&A?
Well, taking over would not be that easy because we had been seeing 6 of them. However, many of them have been answered right away, so they disappeared. There is just one which is still here. It was a question asking what Monte Carlo simulation is. Well, it's computerized after some pharmacokinetic studies in selected patients, I would say burns, for example. And when one has the MIC of the bacteria, some characteristics of the patient, including renal clearance, for an example, you can choose the regimen you would use with the antibiotics in attaining a target. Usually inpatient in intensive care, this target is a 4-time MIC all along the 24 hours with time-dependent antimicrobials, and at least 10 times the MIC for the concentration-dependent antimicrobials. So it allows you to expect the best result with your antibiotherapy without, when you cannot perform drug monitoring on site. I hope this answers the question. Maybe Mathieu has something to add to me because he knows it as well, even better than I.
Oh, thanks. Thank you. No, I think it's you said everything wrong. Thank you.
So because you're in front of me, because you're in front of me, I'm sorry, my camera turned off. I saw a question to you. You answered already with the kind of dressing and its consequences on the procedural pain. Can you answer this question?
Yes, I tried to make it short. Basically, I would return the question and ask, well, if a patient needs a special kind of dressing, it's because the evolution of his burns would benefit from a kind of dressing. Some dressing cause more pain. Some dressing, like with a silver coat, or they need to be hydrated. The recovery of the old dressing is sometimes intimately wounded in the wound, and so the patient needs more analgesia. And in Lille, we really try to personalize sedation and analgesia, but with a strong focus on analgesia, basically because if analgesia is okay, the patient needs less hypnotic drugs, which carry the most side effects. So it's, you probably saw it in my presentation, but we try first to take care of the pains, chronic pains, acute pain, neuropathic pains, and we can go to important combination of painkillers in order to achieve this goal. And it leads to that when we do the dressings, usually we don't need a lot of alpha-fentanyl and propofol, as I told you. It's our basic recipe. Of course, we can add a lot of other drugs, but basically it's this simple recipe. And it's even a way to see if a patient has enough painkillers at home. If a patient needs a lot of painkillers during the wound dressing, it probably means that he has background pain or that he has acute pain at home. And maybe he's not complaining, maybe he doesn't want to take too many pills. And so we need to negotiate with him because this will lead to chronic pains. So basically, it's really a confidence thing, explaining and hearing what are the fears of the patient. Why wouldn't he maybe stop taking some drugs? Maybe because someone in his family told him that morphine is bad or whatever. So we need to discuss. And once everything is cleared, then pain is better, and usually the dressings are less painful.
So I saw see another question you answered to Mathieu. So I will relay this question to Samira. What do you do in your setting when you deal with antimicrobial resistance, Samira? Please, can you answer?
And I think the idea and the most challenging thing is to change the idea that all burn wound, especially the larger percentage, may need antibiotic and empirically. So to change the idea that to implement antibiotic stewardship, it initially was difficult, but after guideline and policy implementation and applying this stewardship in each staff or each person that joined the hospital, it will be from day one, it will be implemented in their training, that we have this program, we have this policy, we don't do empirically give antibiotic for burn or deep wound unless we have culture guided antibiotic prescription. So changing people or medical, what do you call it, healthcare worker idea that all burn patients should start with antibiotic, it was difficult, but after a time and seeing the study and knowing the effect of doing it correctly with the stewardship program, people idea and concept change, and we could achieve more like planned and into the targeted antibiotics. So we will know what culture was there, what microbial was there, and we target it accordingly. And we will plan our antimicrobial administration accordingly. So we will not, that will prevent the develop of resistant organism and bugs. So it was hard, but it was achievable. So I think it every burns unit should have some sort of policy and policy regarding stewardship, and even any hospital, not even burns unit. It's like whole hospital-wide improvement project or improvement steps. Thank you.
So, clearly, pain was very interesting for many people. Two other questions that were asked to Mathieu, and he already answered, but I think that sharing with everybody the answers would be interesting. First, why do we have to avoid the non-steroidal anti-inflammatory drugs in blood patients? I know the answer, but I will let you do it. And second, do you use ketamine?
Sorry, Ronan, I didn't catch the first question.
First question was among the anti-inflammatories, and why do we have to avoid them in blood patients?
Oh yes,
Non-steroidal
yes, the non-steroidal anti-inflammatory drugs. It always surprises me, but they are recommended, especially for painkillers for burn patients. In our experience, we work closely with critical care, with specialized in receiving all the cellulitis of the region, with dramatic consequences once they develop in a patient. And it's probably from there that we inferred that we would use non-steroidal anti-inflammatory drug as little and as less as possible. I must say, we position them as rescue drugs, especially after surgery, when sometimes the patient really needs them and they are very efficient. But we do it after surgery because we can be quite certain after surgery that there is probably no infection in the burns, because otherwise we wouldn't have done the surgery. I mean, the skin graft surgery. If it is excision of a lesion which is already colonized, then I would ask you to be careful if you use them. Some colleagues very near here in Belgium, they use it a lot, and they told me they don't have problem with non-steroidal anti-inflammatory drugs. Nevertheless, well, cellulitis in one patient is really a catastrophic infection. So we have a lot of other painkillers that are very safe to use, and as I said, a combination of these painkillers works very well. So, well, this is our policy in Lille. The other question was about ketamine. Yes, we have used a lot of ketamine. I must say, because of the bad trips, we decreased our use of ketamine, and also because we had a lot of other sedation drugs or that we can use and we can adapt. We have been using esketamine for more than 1 year now, mainly as experiment on our hospital, just to check if the benefit to the patient was possibly better than ketamine. And I must say the results are very, very good. So we are increasing our use of esketamine now for the last year, with more than 1,000 patients who benefited from it. And our position for esketamine is not to spare opioids, it's more to spare propofol, and which is interesting in the elderly patient, in the comorbid patient, the diabetic patient. Every time there is possibly dysautonomia, risk of hypotension, risk of side effects of sedative drugs, esketamine does the trick. It avoids the massive dose of propofol that sometimes we had to use, even if analgesia was adequate. And it is a very, very promising drug. I hope the price will decrease so that more countries and more patients can benefit from this drug.
Hi, sorry everyone. I know I don't live in a low-income setting, but we had a power cut and that disappeared from the screen, and the power finally came back. Everybody can hear me? Yeah. So I know I probably missed a lot of the question. I heard the one about ketamine, and I think I had a discussion with Ronan Lefloc earlier on as well about the use of certain painkillers in managing the pain in low-income setting. I mean, a lot of problem in the low-income setting comes from the access to the actual drugs. The bottom line is, if the painkillers are available is one thing, but if they are too expensive, they won't be able to use them, as they won't be available in the hospital. And that is the problem we encounter everywhere. So it's how do you manage the pain in low-income setting with the money they've got at their disposal to actually buy the drugs. Often the patients have to go and purchase them outside the hospital. So when it comes to morphine, it's complicated. That's why they use widely ketamine combined with and other drugs to fight that problem of the bad trip. But all the drugs that we're using in high-income setting are really good, but often they're not available there. That would be my point for the pain management. For when it comes to Samira's presentation about infection control, it is we were talking about maybe people who have been participating in that webinar could come up with some stuff that they've done in their setting to kind of improve the hand washing system. So some ways of making people doing it better, because maybe if we could share worldwide certain action we've done in our own setting to make this happening better. Same thing for the stewardship of antibiotics. We talk always about that, about lowering the use of antibiotics for the wrong reason. But, you know, every time I travel around the world, I find this is not done. And I find people have put on antibiotics for the wrong reason so often. So if people have some ideas, that would be great to share through these means that we've got with webinar or separately, so we can encourage people, because it's good to talk about it, and but it's good that people actually change their behavior. So that would be my 2 points. And then when it comes to psychological care, I totally agree with you, Eva. There's a lot of lack of support. And then mainly in low-income setting. But what I've noticed recently by all the places I've been, a lot of people just talk about involving the family more, involving the former patient more. And I spoke to a lot of former patients recently who said they'd be really keen to help people who had been injured, which would be also helpful for Ruthan's issues about contractures, using former patients to improve people compliance in keeping their splint and keeping doing the mobilization exercise. We see that always have an impact on a positive impact on the patient. And then including in low-income setting, the families to actually in the rehabilitation, psychological or physical. And then and the combine, and also I train the nurses to do all the exercise and mobilization in our trainings, as we don't have much physiotherapist and ergotherapist. Hang on, we're gonna get occupational therapist. Sometimes I mix up the languages, but I think all these things probably who have specialized profession in high income setting often won't be available in a low income setting. And I think that's why the nurses who are present 24/7 are the one we have to concentrate on to make sure that the quality of the care improve for these patients until there's possibility to pay people to actually do all these specific things. That's my input for now. I'm sorry if I've repeated some things, but I didn't hear what you said before. So that's what's the problem. Is it the time for closing this, or there's some people who have more questions?
I think we are already a little bit over time, Dominique and everyone. It's a bit of a pity because of some technical issues once more. But unfortunately, we won't have time. Yeah. So I suggest that if you would like to get in touch with some of the speakers, maybe they could leave behind some of their contact details in the chat. Because yes, this is such a unique platform, and so that's just one way we can get connected and stay connected. In the meantime, I would like to also remind everybody that, and I'll just share my screen right here. Yep. So this today's session was just a time slot A. So you can see here the top 4 speakers. Now we have a time slot B that's coming up in around 12 hours from now. So this is for those who are in a different region, or for those who weren't able to be present right now. And you see there's completely different speakers from different regions. So if you want to get a different perspective or from other people as well, do tune in for this. And then, of course, we have more days of webinars to come tomorrow on Thursday as well as on Friday, and for some of you that will even be Saturday, depending on what region you're in. So do tune into those webinars as well. And I'd like to, at the same time, invite you to leave give us some feedback on this webinar that you've just attended by scanning this QR code. That will also give you a certificate of attendance if you're interested, if you'd like that. So you can scan this code with your phone. Don't worry if you are not able to scan this code on time, because there is going to be in the next after the Zoom, after this webinar is closed, there will be a link which you can also follow to the same survey. And yeah, and then lastly, I'd like to invite you guys also to remember that World Brains Week is not just about a webinar series. There are local activities happening all over. So have a look on our website and promote these activities. Join them if you are around. For now, thank you everybody for joining us here. And I'd like to thank the fantastic speakers for their input, and wish you a wonderful rest of the day.
Thank you. Bye, everyone. Just get in touch if you need.
Thank you. Goodbye.
Thank you, everyone.